Kak Harisa, kayaknya kita akan mulainya jam 19.25 aja kali ya. Karena kalau memang pesertanya kayaknya juga masih banyak yang narasumber juga masih banyak yang belum ada yang datang. Tapi nggak apa-apa,
Iya,
nanti kita sambil menunggu berjalan waktu aja. Jadi
oke.
pokoknya 19.25 kita start aja.
Ya, siap. Terima kasih.
Ya, thank you. Untuk Pak Iqbal, kita akan mulainya uh, 5 menit lagi ya. Ini sambil saya sounding juga di Instagram, sosial media Instagram. Kita akan fokus ke Zoom. Kita akan fokus. MacBook, MacBook, MacBook. Oke, untuk Ananta, ada namanya Wismandari, tolong rename dan jadikan co-host. Thank you.
Oke, thank you.
Selamat malam, Ibu Wismandari. Silakan open mic.
Halo, Assalamualaikum.
Waalaikumsalam. Selamat.
Salam, dokter.
Coba. Iya, oh, yep, oke.
Untuk Ibu Wismandari, kalau ada share screen mau dites, dipersilahkan ya. Oh, saya matikan dulu. Oh, Pak, maaf.
Ini kita ada itunya nggak sih? Ada apa namanya? VB?
Oh, sayangnya belum ada, Ibu. Kita tidak membuat virtual background-nya, jadi silakan pakai virtual background masing-masing saja.
Ya, ya.
Iya, boleh silakan di share screen terlebih dahulu.
Oke, wait. Hmm, Lah, mana dia? Bentar. Mana dia? Oke. Aman?
Oh, sebentar. Saya lihat dulu di mana ya. Oh, oke. Aman, Ibu. Aman.
Oke.
Paling annotate-nya kan ini kan ada fitur annotate ya. Paling di titik 3 di klik disable annotate aja sih. Tapi
Eh,
bisa.
di mana itu?
Wah, kalau di komputer itu diklik di sebelah kanan atas itu ada titik 3 terus ada klik disable annotate. Tapi nggak apa-apa sih. Semoga aman aja sih Zoom-nya. Semoga aman.
I have no idea where it is.
It's okay. Nggak apa-apa. Nggak apa-apa. Nanti kita kami
Oke. Kenapa mau
mantau, mantau aja. Itu aja mau aku kasih tahu aja. Suaranya aman, share screen-nya aman, Ibu.
Oke.
Itu aja. Oh ya, kami akan membuka Zoom-nya 1 menit lagi. Kita berdoa dulu. Semoga acaranya berjalan dengan lancar dan sukses.
Hmm.
Kak Harisa dan Pak Iqbal, Ibu Wismandari. Saya benar, saya memanggilnya Ibu Wismandari
Wisma aja, Wisma.
aja ya.
Oke.
Baik, semoga acaranya berjalan dengan lancar dan berjalan dengan lancar dan sukses.
Amin.
Itu dari saya.
Ya.
Kita akan berdoa dimulai. Berdoa selesai. Kak Harisa sudah siap ya? Kita akan accept peserta. Nanti kita
Ya.
akan mulai tepat jam 19.30.
Siap, insya Allah.
Oke,
Terima kasih.
saya akan open sebentar. Saya akan open dulu, pasang musik dulu. Saya akan izin share screen terlebih dahulu ya. Sebentar. Aku apa ya? Oke, saya matikan dulu videonya.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat malam para pendengar di Indonesia, selamat siang yang berada di Middle East, dan selamat pagi di Amerika Serikat. Alhamdulillah, puji Tuhan kita bisa berkumpul pada hari ini, dan selamat datang untuk para pendengar di acara hari ini. Kita akan menggunakan dua bahasa, bahasa Indonesia maupun bahasa Inggris nanti. Dan hari ini adalah acara dari Ikatan Ilmuwan Indonesia Internasional, kolaborasi dengan Perkumpulan Endokrinologi Indonesia, Perkeni. Dan hari ini kita akan membahas sebuah topik yang sangat menarik dan berdampak pada banyak orang, yaitu diabetes. Kita akan fokus pada diabetes care challenges and breakthroughs, dan kita akan membahas topik ini bersama para ahli di bidang diabetes, yaitu Dr. Wismandari dari Universitas Indonesia dan Dr. Yogish Kutva dari Mayo Clinic. Saya, Karisa Rahmasari, akan menjadi moderator pada acara hari ini. Mari kita mulai dengan pembukaan dan welcoming remarks dari Dr. Iqbal selaku Ketua Klaster Kedokteran dan Kesehatan dari I-4. Silahkan Dr. Iqbal.
Thank you, Dr. Harisa. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, ladies and gentlemen. Good afternoon, because now I'm in Turkey, and now it is afternoon in Turkey. First of all, I would like to extend my deepest gratitude to Dr. Harisa from Mayo Clinic for her excellent effort in organizing this event, and also to the I-4 team who spent their time to manage the program today. We would like also to thank all of you for your effort and also dedication for this meticulous planning. Because of this one, we are able to gather here today in a well-structured and seamless manner. This is the first one. And second one, we also would like to express our sincere appreciation and special thanks to our esteemed presenter. We have two special presenters today, Professor Yogish Kutva and Dr. Wismandari, for kindly agreeing to share their insight with us. Through this session, we hope we can gain valuable perspective on diabetes and its management. And it is our expectation that today's discussion will serve as a platform for exchanging ideas and fostering collaboration in improving diabetes care. Once again, our heartfelt thanks go to all of you, to all parties who have contributed to making this event possible, including I-4 team, the Cluster of Health and Medicine of I-4, the Indonesian Society of Endocrinology, and Mayo Clinic. Thank you very much for all of you. We truly appreciate your support and involvement. We hope this event will be fruitful and meaningful for all of us. Thank you again and have a great morning. Thank you very much. Back to you, Dr. Harisa. Thank you.
Thank you so much, Dr. Iqbal, for the kind words and the remarks. Moving on, we are going to have Dr. Fatwa as the president of the International Indonesian Scholars Association. Dr. Fatwa is currently associate professor at the City of University in Hong Kong. So please, Dr. Fatwa, and thank you so much for the time that you take this morning or this afternoon.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the introductions, Dr. Harisa. Good evening, distinguished colleagues, healthcare leaders, researchers, and friends from around the world. It is my great honor as the president of I-4, Ikatan Ilmuwan Indonesia International, to welcome you everyone to this vital collaborations and the topic that is very important: diabetes care challenges and breakthroughs. I would like to first send my sincere appreciation and thanks for, of course, Dr. Harisa for the organizations and the moderations, the notable speakers, Professor Yogesh Kutva, MBBS from Mayo Clinic, Dr. Wisnodari from the Faculty of Medicine, University of Indonesia, as well as Dr. Iqbal for our cluster head in health and medicine for I-4. That's for an excellent organization. So as I understand, tonight we try to unite across the borders to confront a very important and global health crisis, which is diabetes, right? So diabetes is, as I understand, not just a medical challenge. It's also also important for our society, right, to solve this. So together with experts from Indonesia and United States, we will try to dissect barriers, try to see if we can push for more breakthroughs and chart for a path towards a more impactful diabetes patient care. And this webinar is very much at the heart of I-4's mission. So we always aim to bridge brilliant minds together to drive solutions, transcending boundaries. So thank you very much to our speakers for sharing your groundbreaking work. And to our participants, I also look forward to engagement throughout this session. So let me finally also acknowledge the tireless efforts from our organizing teams here at I-4, right? So the media, as well as other organizations, the clusters, right? As well as Perkeni, our partners in organizing this event tonight. And those dedications is important to make this event possible. Finally, I also invite you to stay connected with all I-4's initiatives. So please feel free to visit our website to explore upcoming programs or follow us in our Instagram for any updates of our activities. So your involvement will amplify our collective efforts. Okay, finally, without further ado, let's dive into tonight's discussions and thank you again. And I'll give it back to Dr. Harisa. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Fatwa. So we are going to start the main event, which is to have our speakers present their presentations. Before we start, though, I'd like to outline some information and guideline in this meeting. So first, the audience, please make sure that your speakers are muted. And also, if you have questions, we'd invite you to write down your questions on the chat box or the question and answer box. And if you'd like to speak up to ask your questions, please raise your hands and we will unmute you at the time, and I'll call your name at that point. And we do that at the end, though. Throughout the presentation, feel free to write down your questions on the chat. The speakers I will go through the questions and then we will discuss those later. The speakers may also try to address the questions specific to them if they desire. So without further ado, let's go ahead and have Dr. Wismandari from University of Indonesia. Beliau adalah spesialis penyakit dalam dan merupakan konsultan endokrinologi, metabolisme, dan diabetes di FK Universitas Indonesia. Beliau bekerja di RSCM, the biggest tertiary hospital in Indonesia, and we are so honored to have Dr. Wismandari today. Let's welcome her and let's give a big applause at home.
Thank you very much, Dr. Harisa. Assalamualaikum warahmatullahi wabarakatuh. Selamat, kita macam-macam ya. Good afternoon, good evening, good morning to everybody from all over the world. I don't know which one is you, but in my country right now it's good evening then. So thank you very much, Dr. Carissa, for collaborating this meeting. Thank you so much. I think this is a very good opportunity for us to get engaged to each other, because I think this is a very good chance for us to make some maybe collaboration research someday. I think this is a very good to start. So let me share my slides. Where is it? Okay, this is it. Okay. So can you see the slide? Okay, good. So actually, this is something that I would like you to understand a little bit about what happened in diabetes management in Indonesia. This is just a picture to describe what happened in my country. I know you all of you, almost all of you comes from Indonesia too. So maybe you have been outside Indonesia from quite some times. So this is what happened in your country, okay? Okay, this is the content that I would like to share, the picture of diabetes in Indonesia, the challenges in structure and clinical and also in social and behavioral challenges. And last one is the conclusion. So this is diabetes in Indonesia. We have 19 million, more than 19 million adults living with diabetes in Indonesia in 2021. This is big. This is huge number. And I cannot imagine now in 2025, we might have more than 20 million right now. So another facts about Indonesia's diabetes percent, that actually we are fourth most populated country. So we have 280 million people living in Indonesia. And And the increasing prevalence of diabetes right now is also quite huge. We have 10.9% to 11.7% from 2018 to 2023 data from national data. And also, this is something really very big thing for us to be concerned, that we are in the fifth highest prevalence of diabetes in the world based on IDF Atlas in 2021. This is the picture that I think I really like to see this. So this is the projection of diabetes based on 3 scenarios from 2020 to 2025. You can see here, if we do without intervention from 2020, that will increasing crazy until 16% from the prevalence only. And if we do the program intervention, we would see here a little bit decreasing, but still it's very huge. You can see the increasing is almost the same with or without the program intervention. But if you see the program intervention additional with the risk factor control, so you see the increasing is almost none. You can see 8.23 is going to 9.22. So the increasing is much, much lower if we do the intervention and also risk factor control. And of course, if the prevalence is lower, the mortality is also lower. This is proved by the journal from Wahidin. This is from Universitas Indonesia also, and one of the writers is also from University of London. So I would like to overview the challenges, what we have in diabetes management in Indonesia. This is just an overview. First, we have structural challenges. We have the healthcare infrastructure deficiency. We also have policy and regulatory limitation. And we also have resource constraint. And the next one, we also have clinical challenges. We have been doing delayed in diagnosis and also screening. We have a glycemic control suboptimally, and the complication is quite high. And also we have multimorbidity and comorbidity. And this one is also not simple, that we have challenges in social and also behavioral. We have a low health literacy in public awareness. We also have a cultural and traditional beliefs, which is so strong in our country. And we also have dietary and lifestyle factors that is maybe related to the cultural and traditional beliefs as well, and also the socio-economic disparities. Okay, let's start one by one from structural challenges. Bahasa Indonesia ya, tadi bahasa Inggris, sekarang bahasa Indonesia. This is the ratio between doctor and the populations. Based on the WHO and also from Ministry of Health in Indonesia, the ratio is supposed to be 1 to 1,000. But we can see here, the province, we have 1.9 to 1,000, which is higher than what the WHO recommend. But we also have Maluku Utara, North Maluku, 0.2 to 1,000, or in NTT, 0.2 to 1,000. So you can see the discrepancy between province in Indonesia is quite high. We also have the high ones, especially like you see in Jakarta and North Sulawesi, but we also very low ratio in Maluku and NTT as well. Also in Jawa Barat, in West Java, you cannot imagine West Java is so apa ya kalau bahasa Indonesianya cukup baik ya pendidikannya segala macam gitu di West Java, but unfortunately the ratio is still quite low. So this is the data also showing us that we have a limited primary care center and physician in rural area. We have in Bali 2.1 the ratio puskesmas per kecamatan. Kecamatan itu apa ya? Distrik mungkin ya. We have primary care ratio with the district is 2.1 in Bali, but we do have 0.6 in Papua yang di pegunungan. And also in percentage of puskesmas without doctor. Can you imagine our healthcare, our primary care centers without doctors? But yes, we do have that. We do have that. We don't have it in Nusa Tenggara, in Bali, in Jakarta, in Central Java. We don't have it. But you can see in Papua, again, in Pegunungan, we have 54 primary care center without any doctors. Okay, so we can see this is our challenge, of course. And we also have a shortage of physicians in rural. We have primary care centers in rural and area experience shortage of doctors about 11.5%. On the other hand, we have 59% PCC in urban areas experience excess of doctors. So we have shortage, but we also have success. We can see here on the table in Jakarta, we have the ratio is 1 per 350. On the other hand, we have in Maluku 1 per 4,000. Okay, so this is, you can see now the picture is very not similar, very not homogenic in Indonesia. And we also have a problem about the quantity and the quality of the hospitals. We can see here that there are not inequality. This is the ratio of the bed in hospital based on the province. You can see in Sulawesi Utara, North Sulawesi, we have the ratio for the bed in hospital is 2.7. But again, in Papua, we have 0.4. And what about the quality? What about the hospital which has been accredited? You can see here in Yogyakarta, almost 100% of hospital has been accredited. But in Kalimantan Utara or in Papua, not even 70% of the hospital is already accredited. And what about the medicine available in health center in rural Indonesia? I think this is not just about the rural, but also about the urban as well. We have the same problem, almost the same problem that, the puskesmas with essential drugs in Indonesia, you can see 100% in Bangka Belitung, but in Papua is only 73%. And also about the essential drugs in the city, we have like 55% in Maluku, but on the other hand, some of the area is already have 100% of it. So we can see here in the policy and regulatory limitations. We have differences in SOP for diabetes management across healthcare facilities. And also, the existing health policy is not being integrated. All the existing medical stakeholders, like in primary care centers, in public health officers, and also in hospitals. There are no link between programs at PCC nor in public health officer and also hospital. So they've been doing everything by their own. And we have a weak regulations regarding sales of the sweetened beverages. You know this as a result, the affordable and aggressive promotion of sweetened drinks are everywhere. And we also have a weak implementation of the policy. The minimum service standard target have been not reached in several states, particularly in rural areas. What is the factors? There are inadequate health workers, limited funding for management, and unclear communications between stakeholders. And what about the resource? Yes, we do have the resource constraint. Like, despite the government offering free insurance, we do have that for low-income individuals. Still, unfortunately, many citizens don't remain unaware of its availability. So the government already have the insurance for free, but unfortunately, the citizens doesn't even know about it. And the rural area also lack of infrastructure, which is hinders the access to healthcare facility. And of course, at the end, they will increase the overall cost of obtaining healthcare. Now we go for the clinical challenges. I don't know about the other country, but we do have this, that we do have high number of undiagnosed diabetic patients in Indonesia. We can see here from the IDF Atlas for 2021 that we are in the third highest country who have patients which is undiagnosed. We do have above us in China and India, but we are very, very sad that to show you this, we are in the third highest country who has limited screening program and participations, and we also have asymptomatic in early stages. The contributors is that. So that's why we have a late diagnosis, and at the end, we're gonna have poor health outcome. This is the study in Indonesia. This is the characteristic of type 2 diabetes in Indonesia. You can see the patients who has private health insurance is about 27%, and the public from the government insurance, almost 50% of them, and mix is 0.5, and no insurance is 24. You can imagine if someone who doesn't have insurance, it's going to be really difficult for them to go to the doctor or go to the health facilities. The duration, most of the patients is around 58 to 62 months that they have already diabetes since this study is going on. The comorbidities, most of them is the hypertension and hyperlipidemia is about 40% something, and the macrovascular, the heart failure is about 5%, the coronary arterial disease is 5.4%, and the diabetic foot is about 4.1%. And the micro is also there. That's a CKD, we see is quite high number, is 16%, sorry. And the peripheral neuropathy is 9%, so it's quite high number. So this is from the same study. We have the glycemic control still suboptimal. The baseline A1C is quite high, is 9.2. From the 3 years up of this study, they go down into 8%. They has not reached the American Diabetes Association target below 7. This is not an ADA target. This is also Indonesian target from Perkeni. This is below 7% that we want. So only 1/3 that met the A1C and FPG target within this study. Over 40% of patients have a comorbidity such as dyslipidemia and hypertension, and 17% of them having has microvascular complications, and 26% of them having macrovascular complications. So the fact in this study that we get that we have a patient with high baseline of A1C level, we have multiple comorbidities, and we have complications. With these facts, we know that it's going to be really hard for us to achieve the control of the glycemic. And if we have a bad glycemic control, they will go again to the complications. The other challenges, which is also not easy for us to handle, is social and behavioral challenges. Okay, we have a low health literacy and also and why? One of the reason is the misconception about risk factors. They believe that cold rice does not increase blood glucose. Some studies show high knowledge but low adherence. We also have delayed medical attention, the low knowledge on seriousness of diabetes that makes that people late for diagnosis and also treatment. And also why? Because early symptoms are often misinterpreted. For example, the polyuria, they think is just an infection, for example. Or maybe this is just because of the hot weather. So that's why they drink a lot. Okay, so sometimes they misinterpret of the symptoms of diabetes. And also we have medication misuse. So that goes to low adherence to treatment. 80% or almost 90% have low awareness, and 90% of them do not regularly monitor the blood glucose. So the low knowledge to risk factor in treatment will go to the low adherence to treatment. That is the fact. We also have existing stigmas and cultural barriers. One of them is reliance on the traditional medicine. We do have a lot. The use of medicinal plant to lower blood glucose. We do have also home remedies to treat food ulcer. And the cultural norms. We consume the sweet foods before social gathering. We also have perceived stigma. For example, insulin will cause organ damage. Taking numerous medications will lead to organ failure, such as kidney failure. And also, diabetes can be completely cured. And last one, probably like fatalistic attitude due to a blend of culture and religion. They believe that diabetes is predetermined fate or punishment. We also have the facts of about sweet tooth in Indonesia. This is the data from Ministry of Health that 34% of people in Indonesia consume the sweet food more than 1 time per day. 56% of people in Indonesia consume sweet food 1 to 6 times a week. 47.5% of the population in Indonesia consume sweetened beverage more than 1 time per day. And 56% of them consume sweetened beverage 1 to 5 times per week. And of course, with these facts, that will increase trend in the past 5 years. So, based on the data, we see that social and behavioral challenges is different when we compare between urban area and rural areas. What is that? The different risk factor. In the urban area is 1, the consumption of sugar, sweetened beverage. They will more consume of the fast food. They were more having a sedentary lifestyle. And in the urban area, most of them are obese or overweight. In the rural area, they have more people with low health literacy and also more in the cultural beliefs and practices. But in both area, we do have a challenges in smoking behavior. So I think this is going to be my slide and the last one slides to conclusion that we have a widespread challenges. Both rural and urban populations face significant barriers in diabetes management in Indonesia. We also have policy gaps, limited innovative policy, and poor implementations hinder effective care nationwide. Late diagnosis with multiple comorbidities and complications leads to poor health outcome. The rural barriers, shortage of healthcare workers, inadequate facilities, low health literacy, and cultural beliefs are key challenges for us in Indonesia. And last one, in urban challenges are also something that we need to care about, like rapid urbanizations, sedentary lifestyle, and limited access to healthy food contribute to rising diabetes rates in Indonesia. So I think that will be all. Thank you very much for your attention. I'll get back to you, Dr. Harisa. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Fantastic talk, Dr. Wismandari. Banyak sekali yang saya pelajari dari kondisi di Indonesia yang it's a big challenge, and I can only imagine how it is. There is a lot of education that's required, not just by the physicians or the doctors, but also for those who have the knowledge about this condition in particular. You pointed out a lot of great points that I'd like to ask you in more detail. You mentioned about underdiagnosis, right? And underdiagnosis is a big problem everywhere, including in the US, actually.
Yeah.
And as far as I can remember, in Indonesia, we are quite lucky that we have things like posyandu that is quite spread, including in rural areas. And so my question for you is, what have been the challenge in utilizing such, small and kind of organization like posyandu to help with diabetes diagnosis? Because we've been using that for children, for pediatrics, for immunizations, right? Thank you.
Okay. So basically, we not just having posyandu, but you also have posbindu. We also have pandu diabetes, and we also have prolanis. They are all organized by the people, not by the doctors. So prolanis by the doctors. So basically, we have a lot of programs. We have a lot of organizations who conduct the diabetes management. But the problem is not just us, but the problem is about the literacy as well. We are there. The people who understands are there. But also some people who doesn't understand, they will not go to Pospindu. They will not go to Posyandu. They will not follow what the Pandu Diabetes about the dietitian. So Pandu Diabetes untuk diet ya, untuk jadi dipandu untuk diet diabetes gitu. They will not follow because they don't want to. Why they don't want to? Because they don't understand. So what we need to raise is the knowledge that this is important. This is maybe a very small things. This is very simple things. But if you follow, as you can see in my slides in the previous one, that if you follow the risk factor management, that will cost a lot lower in the prevalence in the future 25 years after 2022. So that's why if they understand, it's not just about diabetes, but we also have to manage the risk factors. This is very difficult for us because they don't understand. If they're not diabetes yet, they don't want to go to the doctor. What we do is not just diabetes treatment, but also pre-diabetes, but also people with risk factors, which is very difficult. Even with people with diabetes, they don't go to doctors because they don't feel anything. They don't understand. It's not about the symptoms, because high blood glucose, sometimes they don't feel anything. It's very, very difficult for us to make them understand it is not about just the number, but it is about the complications in the future with goes to morbidity and mortality. So the literacy, I think, is very important in our country. Also, the program, of course, the program from the Ministry of Health dari pusat ya sampai ke bawah itu harus sejalan. Sometimes dari atas dan ke bawah itu nggak sejalan. Jadi misalnya dapat obat A gitu. Di atas bilang boleh-boleh nih dapat obat A, tapi sampai di puskesmas, no, obat ini nggak bisa di sini gitu. Jadi sangat menyulitkan untuk kami dokter-dokter untuk memberikan terapi optimal tuh susah gitu. Di sampingnya tadi ya ngomongin posbindu, posyandu segala macam. Kalau untuk diabetes kita ngomongnya posbindu ya. Kalau posyandu kan anak-anak ya. Kalau kita untuk yang diabetes itu posbindu dan pandu diabetes, program dokternya namanya Prolanis. 3 program itu untuk diabetes.
Terima kasih. Thank you so much, Dr. Wismandari. And I think we are actually going to put a lot more questions and answers at the end of this session. So we are going to welcome Dr. Yogesh Kudva, our next speaker from Mayo Clinic. Dr. Kudva is a professor of medicine at Mayo Clinic, Rochester, Minnesota. And he has been practicing as a diabetologist for many, many years. He has been a vital person in the establishment of diabetes technology clinic at Mayo Clinic. And he's also vital in a lot of research going on right now for the treatment of type 1 diabetes with a closed loop system of almost like artificial pancreas. Let's welcome Dr. Kudva. We are so honored and thrilled to have Dr. Kudva in our webinar today. And a reminder for all of you that we can ask questions. You can put it on the chat, but we can also speak up later at the end of the session. Thank you. Good morning, Dr. Kudva. Thank you so much for taking the time this early morning on a Saturday. And we greatly appreciate you. Thank you.
Sure. Thank you, Dr. Ratnasari. Are you able to hear me? Is this all right?
Yes. Excellent.
Okay, great. Let me share my screen here. And just give me a second here to share. Let me work this out here for a second. Are you able to see these slides?
Yes. Thank you.
Okay. So let me go ahead and do a slideshow. So diabetes care challenges and breakthroughs are what we'll be talking about. I do have some disclosures. They are all listed.
I don't think you've started the sharing yet. I mean, you haven't started the presentation. It's still kind of in the smaller.
Yeah, let me see here how I can do this. Share screen. Window. Let me close everything else here. Just bear with me for a second.
For the audience, feel free to think about your questions and write down your questions on the chat. I look forward to reading all of those later.
Are you able to see this now, Carissa, or no?
I can see it, but I can see on the left side of your kind of the outline of the PowerPoint. I wonder if you'd be able to click on that PowerPoint. Yeah, on the right side. Yeah.
Yeah, let me see. What about now?
I actually, it hasn't changed.
Okay. So let me see here. Let me close this and see view, speaker view. Minimize. Okay. So share screen. I've closed everything else. So
I
let
wonder
me see.
whether starting
Let,
with,
yeah, let me reopen the PowerPoint. I closed the PowerPoint.
okay.
Reopening it now. And what about now? Can you see it now?
We can see it, but I think if you don't mind, we can see it, but I can still see the side of the slide.
Yeah, I can go to I'll go to the slideshow, but each time I go to the slideshow, you seem to be not able to see it. What about now?
Yeah, I don't see the slideshow, but if it's okay with you, maybe we can do this fine like this, or we do the opposite, as in you do the slideshow first, and then you share the screen from there instead of the other way around.
Okay, all right. So let me get back to the Zoom screen and stop sharing. The issue is when I do the slideshow, the whole screen is taken up by the slideshow and I don't see the share option, you know? So that's what's happening here.
Oh, I see. Got you. Okay.
So I closed the PowerPoint. Now I'm going to open it again. And I'm going to do the slideshow. But now I don't see the share option. So
I
share
see.
screen. Share screen. Let's see, that's window. And
I think we can do with however that you can do, because as long as we have the information.
yeah, the other, yeah, okay, all right. Is
And
this
then,
all right?
yeah, that's okay.
Okay, all right. Sorry about
You can
this.
try to minimize the width of the left side of the slides, if possible. If not, we don't have to do that either.
Yeah, I think, let's see. Because, I can go to the, so this is the notes version. So I can go to the slideshow version, but then I don't know whether you can see it. So I'll again try. Okay,
Yeah.
one more time I'll try.
Okay.
What about now?
I can only see I can see your PowerPoint, but not in a slideshow. And I think it's okay because we can actually see the information from the slides.
Okay, so you want me to go back to the notes? Or is this okay? Is this okay?
This is okay. This is okay, yeah.
Okay. Can you see the disclosure slide now?
No, actually, it doesn't move.
It doesn't move. Yeah, see, that's the issue.
Oh, actually, now we can see the disclosure. It just took a while. There's a lag. So yeah, we can see the disclosure.
Okay, so I can go to the, so you can see the disclosure now.
Yes. Mm-hmm.
And is it moving to learning points?
It's lagging. How about this? Would you mind sending your PowerPoint to me and I'll share it from my end?
Yeah, I can do that. I'll just have to open the email and send it to you.
Oh, okay.
I closed the email because I didn't want to, everything pops up, etc. and is
Got you.
disrupting
Okay.
and it's disrupting.
Yeah.
But
Okay.
I'll send it now. I'll send it now, and then you can maybe project. So I'll have to see if this is too big or how this is, meaning.
Oh, actually, Dr. Kudva, you may want to try by pressing F5 to see if all the screen is going to show up, and then you can actually share the screen through there. If somebody told me that from the team, but
5. Okay, I did F5 and share screen. Now the PowerPoint is not there,
oh, okay,
So
I see. Yeah, I think sending it to me probably would be.
yeah, I've sent it. It's gone through. It's
Okay.
gone through the Mayo system. That was your email, right? That is your email, the Mayo email?
Yes.
Okay. So hopefully you will get it soon.
Yes. Okay, there we go. I'm sending it now. I'm gonna download this quickly. And for the media team, can you please make sure that Dr. Liz Mandari is in the room? Because she told me she got kicked out.
I'm here.
Oh, okay. Perfect, thank you. Share. Are you guys able to see this?
Yeah, now yes. Now
Perfect.
I can see it. I can see it. Can the others
It's a
see
full
it?
screen.
Yeah.
Yeah, if you can.
Yeah, I can see it.
Yes, we can see it.
Okay, great. Okay, so let's go to the next slide, please. So these are my disclosures. And you can see that I have consulted and I have obtained product support from various industries. None of them is in any way, conflicted with the presentation, but I do work with several industries. So the next slide, please. So we'll talk about the following randomized trials, and these trials are all impacting clinical practice, and they have been transformational. Now, there may be others also, but in the interest of time, these were the 8 that I picked to talk about. Let's go to the next slide, please. So teplizumab or Tzield to prevent stage 3 type 1 diabetes in high-risk patients. That's one of the treatments that we have been providing in the last 2 years. Next slide, please. So this is a patient who would represent a patient who might benefit from this treatment. So this is a 30-year-old lady who's the sister of someone with type 1 diabetes who is anxious to prevent it and wonders whether she can use a treatment to prevent it. Her fasting glucose is normal. Her A1C is also normal. Next slide, please. And she has antibodies against GAD65, IA2, and zinc transporter 8. So she has 3 antibodies. Next slide, please. So just to reiterate, these are the 3 stages of development of type 1 diabetes. We as endocrinologists generally see patients who are symptomatic, but there is a pre-symptomatic phase, and that is characterized by the presence of antibodies and subtle changes in insulin secretion as marked by an abnormal glucose tolerance test or mixed meal profile. So that is the sort of patient who might benefit. Next slide, please. The approval of this medication was based on this study. It was the medication is called teplizumab, but the trade name is Tzield. Next slide, please. And so these were mostly children, as you can see, age range in the pediatric age group mostly, and mostly had a sibling with type 1 diabetes and an antibody profile that you see here. GAD antibodies were the most prevalent, and IA2 and ICA antibodies were the next most prevalent. Next slide, please. And so when Tzield is used, as you can see, individuals who get placebo get much more type 1 diabetes, whereas Tzield increases the time to development of type 1 diabetes beginning in the first year. And this impact is sustained through more than 7 years of follow-up now. So you can see the Tzield group, 19 out of 44 developed type 1. In the placebo group, 23 out of 32. Next slide, please. So Tzield is associated with side effects, most prominently cell count changes in the first month and rash. The others are not much different, and these are mostly self-limiting. So far the safety profile has been good. Everyone who gets Tzield is offered enrollment in a long-term registry with follow-up for 15 years to see the impact of immunosuppression. So this is an active area of treatment and research, and nearly 300 patients around the country have now received Tzield. Next slide, please. So therefore, Tzield is a CD3-directed antibody to delay the onset of stage 3 type 1 diabetes in adults and in pediatric patients. So the lower age is 8 years. Next slide, please. So our next learning point here is about semaglutide use in people who have type 2 diabetes and clinically important kidney disease, and the impact of semaglutide as summarized in the FLOW study. Next slide, please. So in the FLOW study, people with type 2 diabetes and chronic kidney disease that are at high risk for kidney failure, cardiovascular events, and death were enrolled and followed, placebo versus semaglutide. Next slide, please. And so this was a randomized trial. So everyone who came in had to have a GFR that was 50 to 75 and a urine albumin to creatinine ratio that was elevated. Or they had to have a GFR which was even lower than that. So there were good entry criteria. And the primary outcome was either a composite of kidney failure, so dialysis, transplantation, or eGFR less than 15, or 50% reduction in eGFR from baseline, or death from kidney-related or cardiovascular causes. And pre-specified secondary outcomes were tested hierarchically, which means that once an outcome is not significant, no further statistical testing. Next slide, please. So you can see the key endpoints here. So the first major kidney disease event here, semaglutide delays it, as you can see. The events are fortunately small, so therefore the numbers are small. Therefore, there is a magnification of the y-axis here, And this trial was halted when a certain number of events had occurred. So this was highly significant. Next slide, please. Also, you can see the significant impact, a larger impact on death from cardiovascular disease. Semaglutide is superior. And next slide, please. Death from any cause also, semaglutide is superior, though the impact is not as high as on death from cardiovascular disease. Next slide, please. Obviously, adverse events are an important issue here. As you can see here, adverse events leading to permanent discontinuation was similar in placebo and semaglutide, about 13%, so 1 in 8 people. Diabetic retinopathy and its worsening is an important question with semaglutide because of some early data. Diabetic retinopathy was studied carefully here, and you can see that it was no different between the two groups, so that is reassuring. Next slide, please. So semaglutide reduces the risk of clinically important kidney outcomes and death from cardiovascular causes in people with type 2 diabetes and chronic kidney disease. So this is something that is transforming practice. Next slide, please. So let's go on to automated insulin delivery and endpoints that we observed in the A trial, which was type 1 diabetes with senior citizens. Next, yes. On this slide, you can see that over the years, we've observed that people that are older, greater than 65 years in this context, many times have long-standing diabetes and hypoglycemia unawareness, and therefore are at increased risk for severe hypoglycemia. In this population, hypoglycemia may also result in falls and fractures and cardiac arrhythmias. And therefore, it's important to try and reduce hypoglycemia. Closed loop or automated insulin delivery is an important treatment to test here. Next slide, please. So this study was performed with the Tandem pumps. Tandem themselves were not involved in the conduct of the study. These were provided by Tandem. This was an NIH grant that we had. So 4 centers enrolled people and had 3 12-week periods of sensor-augmented pump, predictive low-glucose insulin suspend, and hybrid closed-loop technology. There was a 12-week extension phase. 30% of people had to have mild cognitive impairment. Next slide, please. So you can see here, we enrolled individuals who were 71 years of age mean. The oldest was 86. They had variable durations of diabetes, and about 30% of them were on multiple daily insulin injections by design. A1C was 7.2%, so they were relatively well controlled. Next slide, please. So you can see here the impact on hypoglycemia. So this is CGM hypoglycemia. So both hybrid closed loop and predictive low glucose insulin suspend compared to sensor augmented insulin pump reduced hypoglycemia significantly. Next slide, please. And they did it in spite of reducing A1C significantly. So therefore, closed loop reduces A1C without increasing hypoglycemia. Predictive low glucose insulin suspend reduces hypoglycemia but makes no difference to A1C. And similarly, you can see that time in range, hybrid closed loop achieves an expansion of time in range. So definitely superior, definitely something to be used in senior citizens who are capable of managing their diabetes. Next slide, please. And you can see the dramatic impact of hybrid closed loop, particularly overnight. And predictive low glucose insulin suspend is not different from sensor augmented pump when it comes to mean glucose overnight. Next slide, please. So therefore, older adults can successfully use this therapy, and it is comprehensive in its improvement of glycemic outcomes. Most participants after the study in the extension phase chose to continue with the hybrid closed loop, and these results will be released released soon. Next slide, please. So we've covered 3 areas now. Let's move on to inhaled insulin. And this was for type 1 diabetes. Next slide, please. Yes. So inhaled insulin has been around for 10 years or so. And we can see here, based on its impact on glucose, inhaled insulin starts working very quickly and has an offset also that is rapid. Whereas the most rapid acting subcutaneous insulin can only achieve an impact on glucose that is delayed compared to inhaled insulin and prolonged. Next slide, please. So Technosphere insulin is marketed by Mankind Corporation and called Afrezza, and it comes in these different cartridges, 4, 8, and 12 unit, and there is now a protocol for equivalence of subcutaneous insulin versus these cartridges. And so this updated protocol was tested in the INHALE-3 study. Next slide, please. Which was a randomized trial, and the results have just been published in Diabetes Care. Next slide, please. So this is the design of the study. So people who were on injections or automated insulin delivery or sensor augmented pump or predictive low glucose insulin suspend could be enrolled and randomized. So they either used the Technosphere insulin and degludec insulin as basal insulin, or their usual care. And you can see that we achieved more than 90% follow-up. Next slide, please. So this was a non-inferiority study. So we showed that inhaled insulin versus usual care group, there is no difference. So inhaled insulin is equivalent. Next slide, please. And one of the concerns is with such rapid action, would it cause hypoglycemia? And again, based on CGM, you can see that there was no difference. Next slide, please. So one of the questions always asked is about adverse events. So inhaled insulin patients did report more cough, but not significant discontinuation because of cough. Next slide, please. So the key points here are that inhaled insulin is non-inferior to subcutaneous rapid-acting insulin. So in people with type 1 diabetes, definitely this is an option that should be discussed with patients. Next slide, please. So the inhaled insulin group had higher percentage of people with A1C less than 7%, but those who had been on automated insulin delivery on inhaled insulin, they didn't do as well, partly because I think principles of diabetes self-management, they might not remember as much once they've started doing automated insulin delivery. So that's an important point to remember for the future. Next slide, please. And so the A1C getting worse did occur in a certain number of people, and that was in automated insulin delivery group. Next slide, please. So safety-wise, cough resulting in, I think there's some animation here, Carissa. So yeah, so severe hypoglycemia was not increased. Hypoglycemia was not increased. There were some adverse events related to pulmonary symptoms, but none serious. Cough was reported. So if people on inhaled insulin have moisture in their throat, that cough is less. So drinking some water before inhaling is an important simple measure. And FEV1, there was no difference between the groups. I think that stops the animation, I think. Next slide, please. So this is Nelson Mandela, who died in 2013 at age 95. Next slide, please. Yeah. And this is Fred Sanger, who won 2 Nobel Prizes for his work with insulin, both sequencing the insulin gene as well as sequencing the amino acids in insulin. And so both of them were born in the same year. Both of them died in the same year. So yeah, keep going, please, with just a couple more tidbits there. So 1958 and 1980. So the point to be made here is to lead us to the next study, and this is a basal insulin study. Oh, I'm sorry, this was a slide out of alignment. So remember this when we discuss the next study, the QUINT-2 study. So let's talk about the SURMOUNT trial there. And so this is an impact of tirzepatide versus semaglutide in people with type 2 diabetes. So this is an older study, the SURPASS-2 trial, sorry, and this is from 2021. As you can see here, individuals could have 3 different doses of tirzepatide or semaglutide, and there were a significant number of people in each group. So nearly 1,900 people were studied. This was a multinational study, but still Caucasian people were about 4/5 of the study population. Next slide, please. So in general, this was the usual population of type 2, some on insulin and many on non-insulin medications. You can see that the change in A1C occurred with semaglutide and also with tirzepatide. It was more with tirzepatide compared to semaglutide, whichever way we look at it. Change in A1C or the A1C level itself, or the proportion who met less than 7% target or fasting glucose. And higher the dose of tirzepatide, more the lowering. Next slide, please. An important other issue here is body weight. And again, we can see that the highest dose of tirzepatide had twice as much impact as a 50% dose of semaglutide. So if semaglutide were to be used at 2 milligram, perhaps this impact might be a little more, but I think tirzepatide is still superior in terms of weight reduction and A1C reduction. Next slide, please. And again, if we look at greater than 5, greater than 10, or greater than 15, highest dose tirzepatide is quite impressive. And it also has an impressive impact on lowering LDL cholesterol and lowering triglycerides and lowering the LDL cholesterol. Next slide, please. An obvious question is about discontinuation of this medication. And again, you can see that tirzepatide highest dose, probably about 9% discontinuation, and semaglutide probably highest dose, maybe 6% discontinuation. So there is a difference there. There is a trade-off here, but lower than what we might have expected. In clinical practice, this may very well be higher. Next slide, please. So this summarizes that over 40 weeks, tirzepatide was first shown to be non-inferior and then met the test for superiority in terms of A1C. A1C was the primary endpoint here. Next slide, please. So now we come to insulin innovation. Efsitora is the Eli Lilly insulin being tested in the QUINT studies. So the QUINT-2 study testing this in insulin naive people was published in the last year. Next slide, please. So this shows a radical change in insulin design. So this is a single chain molecule, and it has an IgG2-Fc portion attached to it, and this way it lasts for longer. So it's given once a week. So 7 times the dose is given once a week. Next slide, please. And so this was a non-inferiority study reported in the New England Journal. Next slide, please. So you can see here there were about 50% of people that received Efsitora versus 50% receiving degludec, and predominantly Caucasian, but not as high. So white was 50% here. Next slide, please. And the rest you can see here. So pretty much standard, individuals in about their 6th decade of life with a BMI mean of about 30, about 10 years of diabetes, and an A1C in the low 8%. And the endpoints here we'll see from the next slide onwards. I think this slide shows us the various non-insulin medications being used and pretty much characteristic of what we see in the clinic. 85% on metformin, and then the others are a little less than this. This is a fast changing field, so GLP-1 and SGLT2 use in future studies may be higher than what you see here. Next slide, please. So this was a non-inferiority study. So you can see that there was not much difference between the two groups with the two insulins, whether GLP-1s were used or not used. Next slide, please. And then other endpoints were CGM-based glucose metrics, also similar between the groups. Next slide. Hypoglycemia is an important component here that we will see in the next slide. But on this slide, you can see fasting glucose was not much different, and insulin dose over time was also not different between the two groups. Next slide, please. The insulin dose over time is looked at a weekly measurement. So degludec into 7, that's the equivalent dose to efsitora into 1. So overall hypoglycemic episodes could look to be a bit higher in the efsitora group, but not statistically significant. Next slide, please. So therefore, in people in insulin-naive type 2 patients, once weekly efsitora was non-inferior to once daily degludec. So this is something that we're going to hear more about and is going to give our patients with type 2 particularly more flexibility. Next slide, please. So what about automated insulin delivery in people with type 2? So the secure type 2 study is an Omnipod 5 AID. Next slide. So this manuscript should be out pretty soon, but at this time we have this summary. So they studied 305 people in a single arm study. So this was not randomized and showed an improvement of 0.8%. But there's no comparator here. Based on this, though, the FDA has approved it for use. Next slide, please. So there is a tandem control IQ study randomizing people with type 2 to either AID system or MDI with continuous glucose monitoring. So this is a North American study, and the results will be announced next month. So look out for these results. This will give us an idea about AID versus a comparator. For example, MDI plus CGM, how much of a difference can we expect? This is really the best way to arrive at these sorts of data. This, when released, will also have an impact on the type 2 population. Next slide, please. So, impact of AID in pregnancy with pre-existing type 1 diabetes. I'm sorry for the typo here. This is the ADAPT study, AID-APT study, and this was from the UK. Next slide, please. So this multi-center study enrolled people with pre-existing type 1 diabetes, and this is something that has been limited in its study before this larger study. Next slide, please. So you can see the baseline characteristics here, approximately 60 people, predominantly Caucasian, with about more than a decade of diabetes in general, and enrolled at about 10 weeks gestation, and then randomized at around 11 weeks. So there's a run-in period and then they are randomized. Next slide, please. So this shows us their pregnancy history. As we can see, there is some pregnancy loss in this population, and about 1/3 did not have a previous childbirth. A1Cs are shown here. So the mean was about 7.6 or higher in the two groups. Next slide, please. So on this slide, you can see the pregnancy-specific target, 63 to 140. What was it at baseline in the 40s, and what happened to it in the study? So the improvement here in the closed loop group was about 20%. The improvement in standard of care was about 11%. So 10% overall, 7 to 14 being the range. So this was statistically quite significant. Next slide, please. And as you can see, it happens, this change happens early and is sustained throughout pregnancy, and particularly the improvement is overnight. There is also a daytime improvement. So throughout 24 hours, there is better control. Next slide, please. Serious adverse events are an important component here, and at least in this study, there were more uncontrolled glucose events, particularly hyperglycemia, compared to the standard population. So an improved glucose control comes with more, at least in this population, comes with more hypoglycemia. So this is an with more hyperglycemia, sorry. That is intermittent. The hyperglycemic episodes are intermittent. Next slide, please. So this is the CAM APS system. So this is the pump here is the Ipsomed pump, and this is from Switzerland. And this is now available for people with type 1 diabetes in various European countries. And there is a pregnancy label that's also available in Europe. This is not available in the US. There is a plan to try and get this out in the US, but we don't know when. Next slide, please. So these were the 8 trials that I wanted to go over. And I tried to give you the main messages from these 8. And I think this is really, these are the treatments that have transformed our practice. So these are the challenges we faced. So obviously to address the clinical challenges we face, we do studies. So there is a high need to prevent type 1 diabetes. People with type 2 diabetes and kidney disease are increasing, and therefore there is a need to change outcomes there. Senior citizens with type 1 need technologies, so they need training and they need some support to get going on automated insulin delivery, which is transformational for them. Many people with type 1 diabetes continue to be on injections, but are challenged to meet better control. Inhaled insulin might make a difference to them. And then tirzepatide is a transformational treatment, achieving more glucose control and more weight lowering compared to prior treatments. And this is a field which is going to grow. Doing insulin less frequently is a high need for patients with type 1. It is a big aspiration for patients with diabetes. It is a big aspiration, and once weekly insulin is transforming. And automated insulin delivery in people with type 2 will address the challenge that we faced with the Accord study 20 years ago, where intensive insulin treatment resulted in more mortality. So automated insulin delivery in this type 2 population could also be transformational if we see more evidence for it. And then AID in pregnancy is a big need. The UK study shows some improvement, but also some concerns, as we saw. So thank you.
Thank you so much, Dr. Kutwa. I'm going to stop share. That was amazing talk that we learned so much. And I think with all the breakthroughs that's been happening over the last several years, most of these medications or devices are mostly available in certain countries, and especially in the US or in Europe, and even some Europeans in Europe, it's not always available either. So the challenge with diabetes is quite broad when, especially when we talk about the global scene, where in some parts of the world, the biggest problem is health literacy and accessibility, while the breakthrough for diabetes management is quite fast in some other parts of the world. So there is an interesting point that I wanted to ask you, as well as actually Dr. Wismandari, about how certain medications nowadays, like tirzepatide and then semaglutide, or we call it Ozempic. Tirzepatide is Mounjaro for type 2 diabetes. I think in Indonesia, Mounjaro just entered the country, if I'm not mistaken. The question is, yes, in the studies and here in the US, many people are obese who have type 2 diabetes. How are those medications used differently or supposedly used differently in patients from certain ethnicities or race where they're not actually obese? Like Indonesian, many of us have diabetes without having the obesity. How do we think about those patients? And we can start with Dr. Wismandari and then Dr. Kudva after.
Okay, thank you. Thank you, Dr. Harisa. First of all, I would like very thank you for Professor Kutwa. I learned so many things, so many new things about what you have been delivered, which is, I don't know when it's coming to Indonesia. I think it's still a long way to go to Indonesia, but thank you. This is a very new for us. So, what you said, Dr. Harisa, is very interesting. I think you are completely having a mistake about what you think the Indonesian people, diabetes people in Indonesia is not obese or overweight. No, you're wrong because most of the diabetes patients in Indonesia is also overweight or obese. So the challenge is not just for poor populations, but also not just for healthy, no, sorry, for the wealthy person, but also in the poor person, they also having an obesity. So what you said about semaglutide, tirzepatide, we do have the semaglutide right now, and we use that quite often right now to treat not just the diabetes but also for the obesity. Even though in Indonesia it's not approved yet as an anti-obesity drugs. I mean semaglutide, it's not approved yet. So if we use anti-obesity semaglutide as an anti-obesity, actually it's still not approved by the government, but we still do anyway because we know that it's already approved in some other country. And tirzepatide, we haven't gotten the approve yet, but it's also in the process in Indonesia. But we still have to wait until in the market, until in the approval from the government. But we don't have it yet, tirzepatide, but semaglutide is already everywhere. But you know the price is not cheap. Semaglutide is not covered by the government insurance, and some of the private insurance also not covered. Every time I prescribe semaglutide, even the private sector of the insurance will ask me immediately, "What is this for? Is this for obese?" Because they think if it's obesity drugs, then it's only for cosmetics. Actually, no, it's not about the cosmetic. Maybe it is a little bit, but for us as an endocrinologist, we think more about the diabetes control. It would be a lot better if we use semaglutide. As Professor Kutwa said, it's also good for cardiovascular and kidney disease. So unfortunately, quite difficult for us to prescribe semaglutide right now. It's getting tighter and tighter for the rules in insurance because they only think that this is for cosmetics in obesity. I think that's what happened in my country.
Thank you, Dr. Wismandari. Yeah, Dr. Kudva, please.
So I think, I think it is a tragedy. I think the fact that diabetes therapies are so much more approved, particularly in the US, and not available in other parts of the world. I think we have to take inspiration, I think, from the HIV community and try and transform this. So this is a place where I have not seen good leadership or outstanding leadership, let me say. The HIV community did it because of outstanding leadership. there is really nothing like what the HIV community has achieved in terms of making medications available around the world, you know. So this really requires like a global approach and a global task force, but also national leaders, you know. Um, so the impact of all these medications on non-white populations seems to be similar to the impact um, on Western populations, you know, or on Caucasian populations, let us say. The body weight in non-white people that predisposes them to type 2 diabetes is much less. But the truncal weight, and particularly the visceral weight, is more out of proportion to the body mass index, you know. So physiologically, all these people will likely benefit, though to what extent we don't know, you know, because even though these studies have been done in non-white people, the analysis that has to be done has to take into account their baseline lower weight, you know. So those data we will see more and more with every passing year, now that these multinational studies are more available. That's only one aspect though, right? I think it's only one aspect of making these medications and these devices available around the world. The good news, I think the most outstanding penetration I have seen of a diabetes therapy or technology is really the Abbott Libre continuous glucose monitor. The Abbott Libre continuous glucose monitor has made such a global entry, you know. So there is a lot of lessons to be learned from studying that, you know. So I think other technologies and other therapies, manufacturers as well as interest groups, should use that as a lesson to try and roll out more access.
Thank you so much, Dr. Kutva. And follow-up question on that actually about continuous glucose monitor. How widely available is it in Indonesia for continuous glucose monitor? Dr. Wismutia.
Yeah. Okay. So if you talk about CGM, right now I think it's getting a lot more. We know that it's not easy to have a control in glucometer covered by the insurance. So I think it's going to be really, really helpful if we do have the CGM, even though some of the CGM only works, let's say, for 2 weeks. And then after that, we're going to analyze for the result. But we also have the CGM which is work longer than that. And we do have now, it's a lot more than what we have in the previous years, but still it's quite expensive for us. Only some of the patients can buy the CGM in the patients. But right now we try to make research for that to make it more available and to make the data, showing the data to the government that this is very useful if we do have the data of the self-monitoring blood glucose to make the diabetes patient more in control. So the research will be showing the data that we need this control of monitoring by the patients itself. And still a lot more research now is still going on. But if you say, is it used in many patients? I would say not yet, because of the price, and it's not available in the insurance. Even from the private insurance, is not covered yet. But if you talk about CGM, yes, we do have, but for the insulin pump, as Professor Kutva also mentioned, insulin pump is really, really rare in Indonesia. But if you compare with the CGM, it's a lot more. Insulin pump is a lot more small number of patients who use it.
That's exciting to hear that there are research going on right now for the CGM in Indonesia. And
Yep.
so there are companies local companies or kind of in the region that work on this? Because over here, it's kind of, we have this 3 brands that we know well, and that's kind of pretty much it. And the cost in the US, if we were to pay out of pocket, is about $100 per month or $150 per month. So it hopefully things become much more available and affordable in Indonesia and other parts of the world. We are actually towards the end of our event today. It's already 8 a.m. here in the US and 9 p.m. in Indonesia.
Exactly.
First of all, I know there are some questions that were written on the chat box. Apologize that we haven't been able to address them one by one. But if it's okay though, I think Dr. Wismandari posted or like emphasized there are so many stigma as well as misconceptions about diabetes in Indonesia. One of them is that taking medications can actually worsen the worsen kidney disease. While in reality, as Dr. Kudva also pointed out, controlling the diabetes, and there are even certain medications that are used to help prevent progression of kidney disease. So that misconception should be addressed because it even happens in, not only in the rural areas, but also in urban areas where people still don't understand that concept. So I think I just wanted to emphasize that for now. Any other points that our speakers would like to make before we close the event this morning or this evening?
Who first?
Yes.
Who first?
Or if there's any other last minute burning question, let's see. Oh, is diabetes reversible? I think I would like to make point here. What do you guys think? What do you think? Is diabetes got reversible? There's a question from one of the audience here.
Yeah, if you don't mind, I would like to answer first, and then Professor Kutwa would like to add more, please. So we know that in the long zaman dulu apa tuh? Udah lama apa sih ngomongnya ya? Udah lama
In the
banget.
past, in the past, yeah, long time ago.
Okay, long time ago. In the past, we don't talk about diabetes, reverse diabetes. We know that diabetes is not to be cured. This is something that we need to be in the same page with the patients. If you want to be cured, please don't think about that, because we are going to give you some medicine, but it's not for curing your diabetes. That's what we have been saying to the patients in the last few years. But lately, we are now talking about going to reverse the diabetes. We try to reverse diabetes. Professor Kutwa also mentioned about new drugs, which is making the diabetes patient going to reduce the weight very much. And with that reason, there is a possibility for someone to have the diabetes, reverse diabetes. So we have a hope right now that patient someday is going to have a reverse in diabetes. But unfortunately, in my country, I cannot say that, because I don't want to make people who have a hope that, okay, I'm going to be cured with our diabetes. No, I'm not going to put that mind in their diabetes. But we know that someday we're going to go there to reverse diabetes, but only from some specific drugs, which is right now, it's not available very easily in Indonesia, like tirzepatide. We don't have that now, not yet, but maybe if it's available, so many in Indonesia, we might say that reverse diabetes, but not today. In my population, it's not easy to say that. They're going to have a big hope that someday they will be cured, but maybe in your country, you can say that now. I don't know. What do you think, Professor Kutwa? Still mute, Prof.
Are you able to hear me now? Okay. So what we have seen from various weight loss treatments, particularly bariatric surgery, is that diabetes can be vastly improved. and perhaps the cure word could be applied. The reason why I say perhaps is because the bariatric surgery population has not done an in-depth study of glucose control. And in my own experience, even though A1C may be normal and fasting glucose may be much improved, there is still probably postprandial hyperglycemia and sometimes unrecognized hypoglycemia in that population. Tirzepatide might make a big difference, because of its much higher impact, and others which are going to come, triple agonists might have more impact. I think the biggest issue globally that I see, which is very sad, is that many countries, the cities are getting transformed such that you can't walk anymore. I used to laugh. I grew up in India. I used to laugh when I heard people from the West coming and saying they drive to a park and walk there. And I used to think I can easily walk to any park close by. Now I can't because there are no sidewalks. So that's an important issue, I think. Whether diabetes is cured or not, taking individual responsibility, knowing what your glucose control is, and making sure that lifestyle and exercise are addressed will help all of us. That I never mentioned in my 50 minutes. I am taking the opportunity to mention it now. Thank you.
Thank you so much for our amazing speakers today. Thank you for the presentations and for the discussion towards the end. I am going to officially end this webinar. Thank you so much for all the audience for the participations and for being here today. Hopefully this information, this event will be helpful. It also is going to be posted on YouTube for anyone who are interested in learning more about diabetes. And again, we can control diabetes. Hopefully, eventually, we'll be able to cure, but right now, focus on diabetes control. So thank you so much, everyone. And before we end, can we please take a picture, all of us together, team media, if we can do that, please? Okay. Media team, I think you're muted. Well, Vanerdo?
Okay. Can you hear me? Sorry.
Yes, I can hear you. Thank you.
I have a four slide, and then I'm still waiting for another for open the camera.
Let us know when the camera is done. So we're
Okay.
not dry, smiling.
Okay. I'm waiting. Okay. Slide 1. In 3, 2, 1, go. Okay. Slide 2. In 3, 2, 1, go.
Okay.
Slide
We
3.
are very Indonesians. We take lots of pictures.
Yeah. Slide 3. 3, 2, 1, go. And last slide. 3, 2, 1, go. Okay. That's it from me. Thank you.
Excellent. Thank you so much, everyone. And thank you, Dr. Kuba, Dr. Wismandari, and everyone. Dr. Iqbal, Dr. Fatwa, thank you so much. Have a good rest of the day. Enjoy the weekend. Bye.
Thank you. Bye-bye, Dr. Khalisa. Professor Kusma, thank you so much. Assalamualaikum.
Waalaikumsalam.